Hi, everyone, and welcome to our EXO webinar. My name is Leslie Van Heil, and I'm a physical therapist and clinical training specialist with EXO Bionics. Today I'm going to be discussing the research behind EXO use in spinal cord injury and stroke. So let's start with the latest numbers. Currently, there are 55 studies that involve EXO. 33 of those have been completed, with 22 still ongoing. 28 are being done in North America, and 27 are being done in Europe, Middle East, and Asia, and 5 of those are multi-center. The diagnoses, you can see the relative breakdown in the pie chart to the right. We have 33 spinal cord injury, 12 in stroke, 3 in multiple sclerosis, 1 in CP, and 4 that includes multiple diagnoses in the data analyses. The target enrollment for all of these studies combined is over 1,200 participants, and 560 of those participants have completed their protocols to date. As of now, the publication numbers are 5 for spinal cord injury studies and 2 for stroke studies. 5 review articles include EXO in their discussions of exoskeletons, and there is a book chapter that also includes EXO. And more trials and publications are expected for 2017. Our areas of study have changed over the years. We started with feasibility, safety, the things that you always have to start with new devices. We have also looked at progression of dosage and the user learning. Then moved into cardiorespiratory effects on the users, looking at walking outcomes inside the device, walking outcomes outside of the device, as in a pre and post training. Our collaborators are looking at muscle activity, amelioration of secondary complications, comparisons with other groups such as people without injury or standard PT, and also augmentation of the EXO training via stimulation, whether it's peripheral or spinal or cortical. And we'll be moving into neuroplasticity in our latest designs. Looking at spinal cord injury, there are 33 studies, 23 of which have been completed and 13 that are ongoing. 16 in North America and 17 elsewhere. There's early studies of feasibility, progression of dosage, and safety, and a learning curve, and you can see the numbers related to that. But the largest study was a pan-Euro study that involved 9 centers in Europe and a variety of spinal cord injuries, which means it included paraplegia, tetraplegia, incomplete, complete, and acute and chronic spinal cord injuries. They trained for 3 times a week for 8 weeks. And they found significant increases in uptime, walk time, and number of steps in the device, so all good progression. The graph to your right shows that the walk time becomes a greater percentage of the uptime, which is also a good sign of progression. They've also looked at the characteristics of the injuries and found that a level of injury had an effect on the outcomes, but time since injury and severity of the injury did not. They also found that skin irritation was noted as a safety issue. How long does it take to learn basic skills in EXO? Dr. Kozlowski and his group at Mount Sinai looked at 7 folks with a variety of spinal cord injury, training once or twice a week for 8 to 24 sessions, up to 2 hours each. So looking at the basic skills, 6 of those 7 performed sit to stand and stand to sit with min assist in a median of 8 sessions. And all 6 of them performed it with contact guard assist or supervision in a median of 18 sessions. 6 of those 7s walked with a minimal assist in a median of 8 sessions, and 5 of those walked with contact guard assist or supervision in a median of 15 sessions. So how hard is it to use EXO in terms of cardiorespiratory measures and reported effort in spinal cord injury? There are 3 studies on this slide, and the top study is related to the pictures to the right. They looked at 8 folks with chronic and more severe spinal cord injury in the sitting, standing, and walking tasks inside EXO, and compared that with people without an injury who were also sitting, standing, and walking in EXO. And they showed that they had very similar percent of peak capacity between the 2 groups during those activities. They also used heart rate and cardiac output to show that there was improved circulation, and yet the tasks were perceived as only light effort, and those numbers are in the bottom right. Also, the amount of work and perceived effort were similar to the non-injured controls, walking normally at the self-selected pace in the EXO. And the second study showed that walking in EXO was an average of 2.6 METs. So this is looking at the amount of work in a different way, and that it was comparable to people without injuries walking at 2 miles an hour. The third study on the slide showed that there is an increasing percent VO2 max and heart rate and so effort in the EXO when reducing the amount of support that the EXO provides and can induce high physical strain. The study also showed that the proximal muscle groups had increased motor output on EMG compared to distal muscle groups. What happens to muscle activity when EXO assistance is lowered? Dr. Forrest at Kessler is looking at that, and this is an example of EMG activity in a person with incomplete spinal cord injury. And you can see on the left that the amount of assistance provided by the EXO is being lowered even all the way down to 0. And just note that the axes on these graphs are all different, but if you had the time to look at everything, you'd see that there's greater proximal activity, as was shown in the previous study I discussed, as well as increased motor activity and better organization of that activity as the amount of assist is lowered. So what about the trunk? A group at ICORD is looking at trunk activity while walking in the EXO with people with complete spinal cord injury. So far, they've reported on 6, and you can see in the graph to the right that trunk muscle activation pattern using EXO is similar to regular overground walking in people without spinal cord injury. The EXO walking overground is in the blue line, and actually EXO walking on a treadmill is in the red line, and the black flat line at the bottom is another device that isn't getting activity. So they showed that trunk musculature is activated below the level of injury, which can add to the postural control of weight shifts in EXO. And even in non-injured participants, trunk activity in the EXO is similar to walking over ground, so the training environment is more normalized. Now, the EMG data from this and the previous study so far has shown that with increased volitional activity, you have an increase in speeds in EXO. So let's talk about speed changes and other functional outcomes. There have been significant improvements in gait speed, walking distance, endurance, and functional balance, and you can see the tests and numbers related to that. And there's a group in Italy. Dr. Bernardi and his group in Italy have looked at pre-post training outcomes for people with subacute to early chronic incomplete paraplegia for 18 sessions. And they found that a significant average gait speed of from 0.26 to 0.40, so it's an increase of 0.14 meters per second. That 0.40 approximates the threshold for limited community walking for SCI, which is 0.44, so it's close. And that 0.14 change nearly meets the minimal clinically important difference, or the MCID, for slow walkers with spinal cord injury, which is 0.15 meters per second, so it's close. And they also show statistically significant improvements in the whiskey, the 10-meter walk test, and 6-minute walk test, and the mobility subscale of the SCIM. Secondary complications affect everyone with spinal cord injury, particularly body composition. Dr. Forrest at Kessler, again, is looking at a group of people with chronic spinal cord injury. She has 8 so far. They've trained 5 times a week for 50 sessions in 2 different exoskeletons, and one of those is the EXO. She's shown significant increase in lean muscle volume, significant decrease in intramuscular fat, and those taken together show the potential for reversal of muscle atrophy and fat infiltration in chronic spinal cord injury. Other secondary complications that have been reported with use of EXO include improved lower extremity strength, improved bone density, improved bowel and bladder function, reduced pain and pain medication use, as well as reduced spasticity. And you can see the numbers related to those. When it comes to pain and spasticity, some of those numbers were people who trained 1 to 3 times a week for 5 to 20 sessions, but about half of them had only 1 session and still reported those reductions. Just as important are psychological and quality of life issues for these participants. Other areas that have shown improvement with use of EXO include sleep, improved mood and motivation, improved body perception, significantly improved quality of life, and a satisfaction of using the EXO. And again, you can see the related numbers for those. Stearns-Udall has presented on 8 people so far, doing interviews with veterans with spinal cord injury using EXO. And she has shown their responses include an appreciation of upright interactions with others, being able to talk to folks eye to eye, a reduction in anger and anxiety, and feelings of control, accomplishment, and hope. So now we'll talk about stroke. And we have 12 studies with 8 being completed and 4 ongoing in stroke. 4 of those are in North America, and 8 more are in Europe, Middle East, and Asia. Several of those studies have shown feasibility, safety, and positive progression, just as with spinal cord injury, and this is in acute and chronic stroke populations. Dr. Nolan at Kessler has looked at dosage comparisons between people who've used EXO and people who have received standard PT sessions. And these are all inpatients. She has shown 150 to 200% increase in dosage for people who used EXO when compared to standard PT sessions in historical matched controls, and also their own PT sessions. Most notable difference, though, is the dosage that occurs at the first session. The standard PT group on average had 7 feet, and the EXO group had on average 443 feet. Dr. Nolan and Ngasian also looked at gait parameter differences walking outside of the EXO versus inside of the EXO. So they're looking at the training environment. They found more normal stepping via improved gait parameters on both affected and unaffected sides walking in EXO compared to gait training in standard PT. On the right, you can see the changes in gait parameters, but it effectively shows that it has more symmetry among the step length, step width, and stride length of the 5 people that are included in that data. So spatial changes, you can see the numbers associated with them also showed increased stride length and decreased step width, along with that improved symmetry. The temporal changes included increased single stance time, increased swing time, and improved symmetry, which is again shown in the graph to the right. But the 2 authors found differences in double support stance time. Dr. Molteni and his group in Italy have looked at the motor control with EMG of people with stroke. And he's found evidence that walking inside the EXO is affecting motor control, stating that it can modulate the timing and intensity of the muscle activity. And this is in both acute and chronic stroke patients. He also, again, verified that proximal muscles showed the significant difference. Let's look at the all-important midline alignment. There's only one case study regarding this, so we would love to see more research in this area. But it showed improved midline alignment of standing center of pressure after 4 weeks of training in the EXO. And on the left, you have the pre-training pressure map with the right foot actually in motion throughout, and the center of pressure being the black squiggly line that is just next to it. So the center of pressure is shifted to the right, and it is moving quite a bit. After the 4 weeks of training on the right, you can see the pressure map of the post-training results with the weight shifted more bilaterally onto the heels, and the center of pressure has a better midline alignment. We also have evidence of training effects outside of EXO for gait speed and walking distance for stroke. It's been shown to increase gait speed and walking distance in people with both acute and chronic stroke, and you can see the numbers related to it. Dr. Molteni, again in Italy, has looked at pre-post training of people with subacute and chronic stroke 3 times a week for 4 weeks. His results showed that on the 10-meter walk test, there was a significant improvement up to 0.56 meters per second in the subacute group and up to 2.25 meters per second in the chronic group. The subacute group met the small meaningful change MCID of 0.06 meters per second. With walking distance on the 6-minute walk test, the subacute group showed a significant improvement up to 205 meters, and the chronic group showed a significant improvement up to 92 meters. It should be noted that the subacute group had better initial numbers on the speed and the distance than the chronic group, and being a subacute group, they also had greater changes as should be expected. Further results from this study showed a significant improvement in lower extremity strength and ambulatory function for both groups. But for the subacute group, there was a significant increase in trunk control and home community ambulation. Neither group showed improvements in spasticity, but neither group really had any spasticity. If they did, it was only minimal spasticity. Interestingly, there were new walkers in both groups. So these are people who could not walk at baseline over ground, but could at the endpoint. In the subacute group, there were 4 additional walkers at endpoint, and in the chronic group, there were 3. In addition to the ongoing protocols in stroke, there are also some pilot studies that are collecting data for much larger studies in stroke. They are Dr. Nolan and the Kessler Research Group, and they've done a lot of work in the motion capture of the kinematics walking in EXO, plus those gait parameters outside and inside of EXO. And Dr. Jayaraman and his group at RIC looking at people with chronic severe stroke versus standard PT, and they are showing some early evidence for 10-meter walk tests, 6-minute walk tests, Berg balance scale, and falls efficacy scales for balance. Looking at functional outcome scores, Dr. Nolan has data of FIM scores on 15 people from inpatient rehab stroke, and they had an average admission FIM of about 27. The EXO group had significantly greater improvement in admission to discharge scores of 27 points compared to historical controls, which was 22 points. And there was no difference in place of discharge. Again, psychological outcomes are important for people with stroke, and 4 people have so far reported that they were more positive and motivated about their recovery when using EXO. Looking at future directions, we're very excited about our multi-center randomized controlled trial for chronic motor incomplete spinal cord injury called the WISE study. It will help to determine the effectiveness of an EXO training protocol 3 times a week for 12 weeks on gait, secondary complications, as well as PT burden. It will be compared to active control, so standard PT, as well as a passive control. It includes midpoint evaluation, endpoint evaluation, as well as a 3-month follow-up evaluation. A similar study in stroke is starting this year comparing EXO training with standard PT, and we are hoping to optimize its use in clinics by determining the most efficient dose and how to integrate it into therapy. A Canadian clinic has developed software that suggests a locomotor training intervention based on the PT's assessments and measures over time. They've presented data on 3 people with subacute incomplete spinal cord injury who trained 2 times a week for at least 8 months. The graph on the right is an example of one of those 3 participants improving in their 10-meter walk speed. And they are showing that how EXO is integrated into their locomotor training program. Anecdotally, the PTs have stated that they have seen improved walking ability in patients that they previously thought were plateaued. Future directions in our research also include combination therapies. A case study reported transcutaneous spinal cord stimulation combined with EXO training in a person with chronic complete spinal cord injury. He trained for 5 sessions. They were able to show evoked volitional lower extremity movement while he was supine on a mat, also perspiration in areas that could not previously, and improvement in cardiovascular control. Brain stimulation could also be used before and during EXO training via transcranial direct current stimulation or a magnetic field stimulation. EEG and EMG will be used to show neuroplasticity in the brain and spinal cord. And all of this is to better understand the underlying mechanisms and patient characteristics that determine responders and non-responders to EXO training. So all of the previous research we've discussed has allowed us to be able to say that the EXO GT is safe and feasible to use for gait training in SCI and stroke. Early evidence has demonstrated the possibility of walking a long time with low effort while still obtaining the physiological benefits of improved circulation. And yet PTs can also still impose a high physical strain during actual PT sessions. Early evidence has also shown training inside the EXO can improve your gait speed, walking distance, balance, and motor activity and control while in the device for spinal cord injury and stroke. It also showed improved gait parameters for a more normalized and symmetrical training pattern in the device for stroke. Given all of the research that we've now discussed, the EXO GT is safe and feasible to use for gait training in spinal cord injury and stroke. Early evidence has demonstrated the possibility of walking long times with low effort while obtaining the physiological benefits of improved circulation. But PTs can also induce high physical strain during the session by lowering the assistance. Early evidence has also shown that training inside the exo can improve gait speed, walking distance, balance, and motor activity and control while in the device for spinal cord injury and stroke, as well as gait parameters for a more normalized and symmetrical training pattern in the device for stroke. Other early evidence of pre-post assessments outside of exo have shown improvements in gait speed, walking distance, and balance in spinal cord injury and stroke, mobility independence in spinal cord injury, and midline alignment in stroke. Training effects in exo-GT may lessen the effects of secondary complications, such as reducing spasticity and pain, and may improve body composition and bowel and bladder function for spinal cord injury, as well as may improve lower extremity strength and psychological well-being in spinal cord injury and stroke. Optimal frequency, duration, and intensity of sessions for acute and chronic spinal cord injury rehabilitation outcomes remain unknown. And these current trials are the stepping stones to better individualized training and efficiently achieve the best outcomes during rehabilitation and eventually in the home. Thank you for your attention during our webinar. My name is Leslie Van Heil, and I'll now be taking some questions.
So one person is asking about the dosage for the bone improvement studies, and had two studies related to that. One was a study that had 3 times a week for 6 weeks training, working at 60 to 70% of the heart rate reserve. So they were really pushing the activity, and they were able to achieve 14.5% improvement in the middle tibia on a CT scan. So it's peripheral quantitative CT as opposed to a DEXA. It should be more accurate, and 14.5% is pretty incredible for a group of people with chronic spinal cord injury. So I'm hoping that those numbers can be replicated. Another study that I had was looking at a couple of folks who had the device at home and were being followed up. One patient was using it at home, and at the 12-month follow-up achieved statistically significant improvement in the proximal femur, but one participant saw a decrease at his 2-year follow-up, so that one is a bit split. But I believe that is with DEXA. Let me see, are there any other questions coming in? As I mentioned before, there's one that was asked about any other studies using EXO with MS, and one was published using ReWalk, I believe, but we have 2 ongoing studies that I'm aware of with MS. One is in Poland and one is at TIER. And the one from Poland is looking to be published in that exoskeleton supplement in the Archives PhysMed journal later this summer. But we certainly do hope that we can expand our FDA indications to include MS as well as other diagnoses with the FDA. Okay, yeah, okay, that looks like it's it. And I appreciate your time and attention and look for that link to come out to you so that you can have all of this information for yourselves. And again, if you have any questions, just send me an email at lvanheil@exobionics.com. Thank you so much.